especially in the setting of a low EF. This is what you always want to have in your mind, this 4-box of are they congested, meaning are they volume overloaded? Do they have orthopnea P&D? Do they have JDD? Do they have, some of this is like imaging, like the hepatomegaly, it's hard to feel on exam, but you can. Are they edematous? Do they have pulmonary edema? Do they have lower extremity swelling? And then, sometimes you can get a hepatojugular reflux. So those are all signs that someone is congested. So you first want to know that. Are they congested? Are they not congested? And then the second thing you look at is, are they warm or are they cold? Meaning, even though they have heart failure, systolic heart failure, are they warm or are they cold? Or do they have signs of good perfusion or not? So in this, I'll show you 2 different charts of kind of how to think of this. But if they're congested, if they have a SWAN, and we'll kind of go through SWAN and some SWAN numbers, but is their wedge, are their filling pressures normal? So right-sided filling pressures, you can kind of measure CDP, left-sided filling pressures, a wedge pressure. And then for perfusion, you're looking at their cardiac index and output. So if they have low cardiac perfusion, you'll see sometimes renal failure start, very narrow pulse pressure. They can get obtunded, low sodium, cool extremities, and then they don't tolerate any guideline-directed heart failure medical therapy a lot. And that's often too a sign when people get in the hospital and you start having to remove heart failure medicines. That is a problem. That is a sign that they're on a bad trajectory of their heart failure. Even for those of us that see them in clinic, that's also a bad sign. If you are having a heart failure patient, especially if they're young, they may want advanced therapies in the future. If you have to start removing their medicines because they're getting more hypotensive, they're not tolerating, and they've been on good guideline-directed therapy for a long time, that's a problem. That usually means they're on a bad trajectory. So kind of the same thing. This is just looking at what do you think the worst box is? I guess I'll yell it out. Who thinks the worst prognosis is warm and wet? Warm and dry. Cold and wet. Raise your hand. Cold and wet. Cold and dry. Cold and dry. It's actually very hard to treat cold and dry sometimes because you have to give them fluids. They can sometimes not be responsive. Obviously, anybody cold is worse than anybody warm. They'll have a worse prognosis. But so for cold and wet, so basically that is decompensated heart failure and cardiogenic shock. You can have normal blood pressure. That is where people get tripped up seeing heart failure patients that are in cardiogenic shock. It's really one of the shock states that you can have a normal blood pressure and be in cardiogenic shock. And sometimes that's driven a lot by the diastolic blood pressure is so high because the systemic vascular resistance, which we'll go through a little bit, the systemic vascular resistance goes up so much because the kidneys are secreting all these hormones. Because the kidneys, don't tell Dr. Hendon this, are smart but stupid. They see things as your body's bleeding out or not. So if the kidneys are not getting good blood flow for whatever reason, it acts like your body is bleeding out. So it secretes all the hormones to try to really clamp down on all your blood vessels to keep blood volume in. And so if it's cardiogenic shock and the kidneys aren't getting good perfusion, all it's doing is clamping down the blood vessels, increasing afterload so much. That's why in classic cardiogenic shock, you see really high systemic vascular resistance because all those blood vessels are so clamped down. Now you can have some mixed shock pictures and some of those are a little difficult to treat, but true classic cardiogenic shock is narrow pulse pressure, high diastolic blood pressures often, and really clamped down. So in looking at some of the things we talk about from a hemodynamic standpoint, so stroke volume basically refers to the amount of blood ejected from the heart in a single beat. Preload, we hear these terms a lot, preload, afterload, contractility. So preload basically is what is left in the ventricles at the end of diastole. So diastole is where the heart fills with blood. Systole is where it contracts. So at the end of diastole, that kind of represents your end diastolic volume, We talk about things as far as like a LVEDP a lot, what's your end diastolic pressure. All of these things are trying to assess how much preload you have in the system. So preload refers to volume. Afterload refers to pressure. So afterload is the pressure that the ventricles have to contract against to get blood out. So pulmonary vascular resistance, PVR, is representative of the vascular resistance that the right ventricle has to pump against into the lungs. And SVR, systemic vascular resistance, is what the left ventricle pumps against to get blood into the aorta. And then contractility refers to force. So how much force can the heart generate to pump things out in a single beat? So we always talk about, nobody talks truly about Frank-Starling curve, but we always talk about the curve. They've fallen off the curve. If we can get them back on the curve. This is the curve. So Frank-Starling curve is basically a hemodynamic. So this is a measure of preload, so your end diastolic pressure, so technically LVEDP. So for LVEDP, you know, we measure it in the cath lab, but it's hard to measure in the ICU. So what is the best marker of LVEDP in the ICU? Somebody say it louder.
CVP.
CVP is right-sided. Yeah. So in the setting of no mitral valve disease, no significant pulmonary stenosis or anything, LVEDP equals left atrial pressure, which equals pulmonary capillary wedge pressure. So when we're looking at those numbers, and you know, we don't wedge swans as much here, that's kind of a cultural thing. And so what is the best marker for wedge pressure that we do monitor regularly?
PAD.
Yeah, so yeah, PA diastolic pressure. So again, in the absence of like vascular disease and things in the pulmonary vasculature, your PA diastolic pressure should be fairly equal to your wedge, should be pretty close. And so that is your preload. And then this is your stroke volume or your cardiac output. So when people are really decompensated, when they get really volume overload, they get way too much preload, all the pressures in the heart go up, they fall off the curve. When their contractility goes down, their curve kind of comes into different views. So instead of their curve being normal, they fall off the curve by kind of going this way. And that's where you have to know in your head what you're treating. If they're volume overloaded, you have to figure out a way to get them decongested. If they have contractility issues, you have to find a way to compensate for that. So that's the Frank-Starling curve. And then preload, you can increase preload with volume expansion. A lot of you all know that that's why, like in Impella patients and things, and we'll talk a little bit about Impellas and why, you know, preload and things is important, but blood is the best volume expander. Of all the fluids and things that we give, blood will stay in the system the best because it's the most isotonic to blood. And so when you give normal saline, lactated ringers, you know, albumin was in phase for a while. We use also more albumin here than most places, but none of those things really stay in the vasculature. They end up staying for a little bit and they help, but they eventually still get spread out into the tissues. This is another thing we'll talk about, and a lot of you all have heard me talk about this at times, but when you're talking about preload reduction from a medical therapy, if somebody has really bad RV failure, too much preload, or you give nitroglycerin and they get really sick because they have RV failure and they're preload dependent, nitroglycerin affects preload. There is some afterload reduction, but it lowers blood pressure really through preload reduction. It causes venodilation, and so all the venous system dilates and blood kind of hangs out and does not return to the right heart as much. I hear it, people want to use it for afterload reduction a lot. It will do some, but not well. It is not a good afterload reducer. You'll get blood pressure drop, but mostly through preload reduction, which in MI patients is really good. That is why we use a lot of nitroglycerin for MI patients, and it is a direct, the one arterial system it does help with is the coronary vasculature. So it does have coronary vasodilation. So things that determine preload, blood volume as we talked about, body position, if somebody is sitting up, then it decreases their preload. If they lay down, you can increase their preload. Increase in intrathoracic pressure, you hear me talk about this a lot. PEEP is terrible for the right heart. All that intrathoracic pressure drops your preload and venous return, and the right heart does not tend to love that. Same thing, increase in pericardial pressure, that happens usually, you can get that in cases of constriction, but the most common thing we see for that is pericardial effusions. Increase your pericardial pressure, it also compresses the right heart. That's why you see pericardial tamponade, and it's mostly you see RV diastolic collapse, is because all of those pressures affect the right heart the most. And then, you know, AFib in these sick patients can be bad because sometimes 20% of your cardiac output comes from the atria. So if you go into AFib and you lose that atrial kick, or we talked about this a lot in the cardiac surgery patients, that's why we've been really a lot more diligent in trying to put in A wires and not just B pace post cardiac surgery, because the atrial kick really helps with overall contractility and cardiac output. Afterload, again, is the pressure that the heart is pumping against. So if you decrease your systemic vascular resistance, you will increase your cardiac output, and we'll go through drugs that affect that. If you have increased afterload, you're making the heart work harder. If your afterload of what the heart is pumping against is high, then the heart has to pump so much more to get blood flow out, because that's how the heart works. The heart flows in a pressure system. So to get blood to flow through the heart, the pressure from behind has to reach and exceed the pressure from before. So when the left ventricle squeezes, its pressure has to go up to the point that it will open the aortic valve, so it has to meet the systemic pressure in order to eject blood from the heart. And if your afterload is so high, it makes it so much harder for the left ventricle to reach that pressure to get blood flow out. So, direct arterial vasodilators. The two most potent are nitroprusside and nipride. Nitroglycerin, as we talked about, has some very weak effects, but has some arterial vasodilation, but I would never use that as a primary afterload reducer. Hydralazine is kind of the oral or IV version that is also a direct arterial vasodilator. So they don't really affect contractility any, but if your SVR is so high and you start one of these, it will kind of decrease the work of the heart. Contractility will automatically improve usually. Inotropes, so the two inotropes that can lower afterload, dobutamine, milrinone. Milrinone even more. You have to be very careful with milrinone because it's renally excreted. So in a lot of cardiogenic shock patients, their kidneys are not working well. So you have to be very careful with milrinone because milrinone is also slower in that accumulation. Dobutamine is a much quicker on-off. Milrinone takes a while to wean off, and it takes a while to get the full effect. So you can start it the first couple hours, they do okay, but then they'll get wicked hypotension later if you're not careful.
And I think I'm saying this correctly. Like, you may turn your drip off and they continue to look, and you may think they're looking well for a while because it's so slow to be excreted. They may look well, and then
that's right. You're talking about in the weaning off of them,
mm-hmm.
Yeah. So she's saying same thing happens in reverse. As you're weaning, you think you've got somebody decongested, you're weaning milrinone. As you're coming down and off of milrinone, that leaving effect takes a while. So you may turn it off the first couple of hours, they do good, but it's really that hour 4 to 12, depending on how bad their kidneys are, as to when it leaves. And then direct arterial vasoconstrictors, phenylephrine is a direct arterial vasoconstrictor. It really has no other function other than that. That is why I hate phenylephrine in cardiogenic shock patients. There's only a couple scenarios that you should use phenylephrine, and that usually is in like hypertrophic cardiomyopathy if you have obstruction and you're needing to slow contractility. But in true cardiogenic shock, you will usually make things much worse on phenylephrine. Norepinephrine has potent arterial vasoconstriction, epinephrine, high-dose dopamine, and then vasopressin. Okay, so contractility is basically the true cardiac performance. This is independent of preload, independent of afterload. It's talking about truly the cardiac muscle and how it's performing. So inotropes will increase contractility, epinephrine, milrinone, dopamine, dobutamine, digoxin or digitalis, norepinephrine. Negative inotropes, so this is always what happens, right? Somebody comes into the hospital, AFib with RVR. This is like another Achilles heel of mine. AFib with RVR in the ER. You don't know what their EF is. Maybe they've had a normal EF in the past, but they come in with heart failure symptoms. They have pulmonary edema on their chest x-ray. They have a clinical history consistent with heart failure now. You have to be careful about what you start for rate control. So calcium channel blockers are very potently negative inotropic. So if you have a heart failure patient and you give them calcium channel blockers, you can flip them into cardiogenic shock fast. Beta blockers, you can too. Beta blockers in time, that negative inotropic effect wears off early. That's why if you have somebody that has heart failure, you don't stop their beta blocker when they're decompensated, unless in rare cases. But for the most part, you keep them going because it's kind of lost that negative inotropic effect. But when you have somebody that's had a big anterior MI, you want to give it a few days to see what their course is before you just start hitting them with beta blockers. And we're so used to doing that because that's one of the hallmark therapies of treating MIs and things is beta blockers. But if their heart is weak, it's newly weak, and you give them a beta blocker, you can send them into cardiogenic shock. And then some of the antiarrhythmics have some negative inotropic properties too. So this is one of my favorite charts, except for I left off NiPride, which I realized this morning, but anyways. So this is kind of a good flow sheet. All of them do a little bit of different things, and some of them have more potent inotropic effect, more potent afterload effect. But norepinephrine really has all three. It increases contractility, but that's mild. It's not a good inotrope. It has some venoconstriction, and it has some arterial constriction, so it will increase both preload and afterload. Norepinephrine is a very strong inotrope. It's also a very strong vasoconstrictor. So sometimes epinephrine is tough because if they're in cardiogenic shock and their SVR is already 2,500 and you start them on epi, you might make things worse. You'll get the contractility part, but you will make their SVR high. The other thing about epinephrine that's really tough is epinephrine is a very strong splanchnic vasoconstrictor. So all of the arterial system in the GI tract will get very constricted with epi. So that is why you see lactic acidosis. You'll see a delayed clearing of lactic acidosis is because it typically causes you to generate some lactate from the gut. That is the fine balance of epi. And then, if you become acidotic because of lactic acidosis, then you stop responding to pressors and things like that sometimes too. So it's a very fine balance with epi, but epi is a very potent inotrope and it's a very potent vasoconstrictor. Again, phenylephrine, pure alpha vasoconstriction. Dopamine sucks. There used to be all this theory of low dose dopamine, mid dose dopamine, high dose dopamine. There are not many of us that use dopamine. I've not seen a ton. I mean, dopamine's probably like fourth or fifth line here, but dopamine does all three. It's just very dose dependent, and some of that's a little bit of a wash too. Dobutamine, very potent inotrope. It has some arterial vasodilation, not a ton, so it will increase contractility, reduce your SVR some. Milrinone is also inotrope that will decrease your SVR dramatically. And then vasopressin is really a pure vasoconstrictor. It also causes some venoconstriction. So we're going to talk about MCS today too, and so I thought I'd go ahead and kind of throw this in as far as what does MCS do in this situation. We're really only going to talk about two that we utilize here, which is intra-aortic balloon pumps and Impellas. So with a balloon pump, and we'll go through this in a minute, but a balloon pump will decrease afterload. So again, a balloon pump sits in the aorta, it inflates in diastole and deflates in systole. And that deflation in systole kind of causes this effect of kind of pulling blood out of the ventricles, but also that negative energy helps reduce afterload. So that is really how a balloon pump will help with cardiac output, is through afterload reduction. It's not a strong help with basically increasing your cardiac output, because it really only provides about half a liter of flow a minute. Impella is a direct LV unloader, so it will drop your preload dramatically. That is why you have to be very careful about diuresis when you put in a pump, right? You have this patient that comes in very volume overloaded, but the moment you start putting that pump in and you sucking blood out of their LV, you're taking most of their preload out. Now, sometimes you can diurese them, but usually when you put in an Impella, you are there for support, decreasing myocardial oxygen demand. We'll get into that in just a little bit, but you have to be careful early as you're on full support diuresing, because you'll get suction and your device won't flow well. Really, you want to start diuresing more aggressively once they've kind of recovered and you start weaning the pump. As you wean the pump, their LV and diastolic pressure goes up, their wedge will go up, and you'll have more volume to diurese off. All right, Swan-Ganz catheters. So this is the hallmark of hemodynamic monitoring in the ICU. It is hard to fly blind in predicting where people live without a Swan. The only time in shock that I personally don't use a Swan, and I think we're going to probably protocolize it a lot once we get it to everybody, is when we have a right-sided Impella. Anytime you have the lines and things in the right side of the heart, you form clots on all these little catheters and it gets sucked into the pump. But in general, you should always have a Swan-Ganz catheter when trying to manage a shock patient, especially one that's on multiple drips and pumps, because you just are flying blind otherwise. So your right atrial pressure, when we measure in the cath lab, we measure truly a right atrial pressure. In the ICU, we monitor a CVP, which is an estimate of right atrial pressure. And then pulmonary artery pressure, we don't typically wedge here, but again, PA diastolic pressure should be a good guide to the wedge pressure. The one thing we've had trouble with in the ICU, and nobody can tell me how we can fix it, so we're still a work in progress, but in the cath lab, numbers will be very different than when they get to the ICU sometimes. We don't know why that happens, but it just happens. Okay, so in looking at left-sided parameters, so ejection fraction, people are always hung up on what is the ejection fraction. They're always hung up as we're weaning pumps on what is the EF. It doesn't matter. It's really about cardiac performance almost always. Your EF can be normal and you can have poor cardiac performance. Your EF can be really low and you can have pretty good cardiac performance. So really, in looking at the cardiac output and the cardiac index is important. So the cardiac output is the blood ejected over 1 minute. The equation is stroke volume times heart rate. That's cardiac output in liters per minute. Normal is 4 to 7. Cardiac index is 2.5 to 4. And so in Impellas, especially, kind of that is where we started talking about this concept of cardiac power output. It's been the strongest predictor of mortality in AMI cardiogenic shock, which is where it's been studied the most. But basically, it's just a marker of cardiac performance. So severe or severely reduced cardiac performance is kind of marked by a CPO less than 1. And then you have your mean arterial pressure, systemic vascular resistance, wedge pressure, LVEDP, LVEDB, which again is basically wedge pressure unless you're in the cath lab. All right, so here's a case. Miss Ima heartbroken. She gets admitted to the unit after an anterior MI. She's receiving 2 liters of oxygen. Oxygen saturation's 94% on norepinephrine and epinephrine. Blood pressure is 92/68, heart rate 115, respiratory rate 26, CVP is 20, PA pressure 52/38, cardiac index 1.6, and a mixed venous saturation of 36 on norepinephrine and epinephrine. So what do we think? Is she Where does she fall in this? Is she warm or wet first? Wet. Cold, warm or dry, cold or wet. So she's wet, and then dry or let's see, warm or cold.
Too early.
Apparently I should drink some more coffee.
She's cold.
Yeah, cold, right? So she's got a mixed venous of 36, cardiac index of 1.6 on 2, and she's had an anterior mine. So what are we going to do next? Would you add another drip? What things would we do?
I think she needs some squeeze.
How are we going to get it to her? Somebody throw me out an idea. It can be anything.
Impel
I
us.
was gonna say, I think that she needs maybe some dobutamine maybe, a pump, and then maybe eventually diuresis.
Yeah. I think, so I'm obviously biased, but the data supports me. She needs a pump. It's time. All the data in AMI cardiogenic shock shows that the earlier you put a pump, the better. If you think about, especially in, there's lots of reasons people go into cardiogenic shock, but most commonly is acute MI. And in the setting of acute MI, they've just had this huge ischemic event. The heart is really irritated. The muscle is, has died partially. It's been really ischemic. That muscle is difficult. The problem with inotropes and vasopressors, especially inotropes, is you're kicking this heart over and over and over. That is its goal, is it is getting into those cardiac myocytes and telling it, you need to work harder, you need to squeeze harder. It is increasing your myocardial oxygen demand, which in the setting of AMI is not good. Like, this heart just went through a huge ischemic event. It lost a lot of oxygen supply. And so kicking it while it's down is pretty rude. And so that is why all the data about Impellas are good in this situation, because it truly unloads the heart. It sits there, it sucks blood out, and it kind of allows the heart to rest and heal instead of just kind of kicking a already beaten heart. So we are going to talk about balloon pump a little bit. So balloon pumps inflate during diastole, deflate during systole. They decrease afterload, increase coronary perfusion, mild increase in cardiac output, but has no effect on contractility. The thing about balloon pumps is they've now been shown not to be helpful in AMI cardiogenic shock. It's been reduced to a class 3. We still see it from time to time, especially if somebody has come in from outside hospital with a balloon pump. There are places that don't have Impellas. And then sometimes if they have a mechanical aortic valve or a reason they cannot have a left-sided support device, some people will try to bridge them with a balloon pump. So you will see it from time to time. There are a couple other situations we use it. The biggest thing I see is people not looking at their position. So that's the one thing, especially people coming in from outside, is they've been in transfer. You don't know where they put that balloon pump. So if you're ever seeing a balloon pump patient, you have got to get a chest x-ray first from jump. So actually I made this for you a long time ago, this little
Yes.
drawing. But you can see the lung. You're basically looking to see where the balloon pump is, and you want to look at the carina of where the trachea branches. So you want it to be above, usually 2 centimeters above the carina, in between the second and third intercostal space, or between those ribs. So you want to make sure, otherwise the biggest thing with a balloon pump is you don't want it near the kidneys, and you don't want it to be inflating and deflating right across the renal arteries. Okay, so always, if I could instill anything about a balloon pump, is to make sure that you are getting a chest x-ray when they arrive, and really every day, to make sure it's in proper position.
Yeah, so what they'll do is they'll come in from another Morristown, wherever, and come in with a pump. And I say this for our audience, even if maybe your critical care team admits them and get an x-ray, and just make sure that it's not obstructing our renal arteries.
Yes, it's true. All right, so we have lots of impellas. I didn't make an actual slide with the 5.5, but this is a CP, has a little pigtail at the end and sits in the ventricle, and this sits in the aorta, and it sucks blood from here and dumps to here, okay? Let me pass this around. Everybody can look at it. This is a 5.5. There's no pigtail at the end, but kind of similar concept. It sits in the ventricle like this, it sucks blood from here and dumps blood there. So Impella works because, again, it sits in the ventricle and pulls blood out of it. So it decreases preload by reducing your LV end diastolic volume, reducing your LV end diastolic pressure. It increases your mean arterial pressure, and it increases your cardiac output because it's delivering up to 4 liters of flow per minute. And so it does this too, like once you start reducing that volume, you reduce the wall tension, you increase myocardial perfusion, and you decrease myocardial oxygen demand. So that's the biggest thing, especially in AMI, is you're always wanting to reduce myocardial oxygen demand. The heart will perform better. So when you're looking at an Impella console, there are a bunch of things on this screen that seem like, you know, hoodoo to a lot of people, but the biggest things you want to look at are your aortic placement signal in red, your LV placement signal in white, your motor current here. You know, the cardiac output index is kind of just a marker, and that's where you're getting your flows. Your P levels and controls all fall on this side. And so not only are you looking every day, especially if you're taking care of the same Impella patient over and over and over, you kind of want to get a glance at these numbers. Where do things sit today versus yesterday in looking at the motor currents and looking at your purge? This is the purge pressure. Sometimes we'll talk about that, especially some pumps can clot, and your motor currents and purge pressures will do all kinds of crazy things. But looking also at this relationship here between the aortic pressure signal and the LV pressure signal is also important. If the Impella gets malpositioned, or if the heart is really struggling, they will not be together. They'll kind of be very discordant. And so usually as things improve, if it's just truly because the heart is so bad, then as things start to improve, you will see those curves merge again. Anybody have questions about the console? All right, so again, cardiac power output is sort of the marker of cardiac performance. It's been the #1 thing to correlate to mortality. And there's a whole calculation. I'm not going to go through it. We all have our little calculators, but basically you want to see what your cardiac power output and kind of keep a trend of that, because it's important to follow it over time. That can kind of tell you, are you progressing? Are you not? Is your support device helping? Is it not? Do you need more support? So, you know, especially if we're talking about escalation, if you're talking about escalating a CP to 5.5, trending your CPO can be helpful, because if you're still struggling, you put in a device and their CPO is not coming up, they may need more flow. So early escalation is always better. So we often identify where the Impella is positioned based off echo. So this is what's called a parasternal long axis view on echo. It's really the best to measure this. This here is the aortic valve. Yeah. Aortic valve, ventricle. This is the Impella. And then the mitral valve kind of sits, you don't see it as well in this picture, but it kind of sits right here, and you'll see some of the cords and papillary muscles that way. So you want to, #1, look at the depth of the Impella, but you also want to look and see where the Impella is directed to. So ideally you want it free of all structures and directed towards the apex. Sometimes if people start repositioning Impellas at bedside, if it was in the apex, it can get pulled and put under a papillary muscle. Sometimes they can come up that way if it was put in under duress and they didn't know where it was put. So if it's under a papillary muscle and it gets into that papillary muscle, it can lead to hemolysis, and it will lead to a lot of suction because it can't pull. It's up against that wall. It can't really pull blood. So we'll talk about that in a minute. And then same thing, if it starts, sometimes you'll see them leaning up against the septum. And if it's hitting the septum a bunch, sometimes you will get VT and ectopy with that. So for 5'5", you typically want the depth to be about 5 centimeters. For a CP, around 3.5. My biggest thing is if you have no hemolysis, you have no arrhythmias, and you're flowing well, leave it alone. You know, some people get way too, repositioning it way too much, and that you can start pulling it into all kinds of places. So, you know, if a CP is at 5, but it's flowing well, you have no hemolysis, leave it there. So suction, probably one of the most common alarms that you'll see. So suction, you'll get a drop in flow, you'll get a drop in the mean motor current, and usually you'll see on the Impella that you can get a drop in blood pressure. So this can be from a lot of things. Always want to think about position and volume. Those are the two things when you get suction. Is it under a papillary muscle? Is it directed towards something it shouldn't be? And is there enough volume? So there's a pressure sensor on all the Impellas that are not accurate, but this pressure here is supposed to be a marker of like the LV end diastolic pressure. It's not accurate, but if it is negative 30, negative 40, usually that's either a hallmark that it's a volume problem or it's probably not in a good position. The more negative it is, the more trouble you may have in diuresis. Those are the patients that you'll see if their LV end diastolic pressure on the pump is reading negative 10 and you try to diurese them, you may start to get suction. And that just may be a hallmarker that you need to wait a little bit longer, or you have to turn the pump down some. So if you get suction, you should go down in your P level, assess the volume status, and assess your pump. That's where an echo is helpful. Try to assess where the pump is located and then adjust accordingly. So this red alarm, Impella position in the aorta, that usually means the Impella has come back. Now you're hopeful that you are in this situation and not this situation. This situation, the whole Impella, pigtail and all, is out of the ventricle. In this situation, the pigtail is still across, so usually you can still advance the pump back into the right position. But basically on the screen, it will say Impella position in the aorta. You won't see an LV tracing at all, and you'll usually see a very, very flat motor current. So you want to reduce the P level and then under echo, push it back in. Same in reverse, the red alarm of Impella position in the ventricle. Basically you can see the aortic pressure signal now kind of looks like a LV pressure signal. So that basically means everything, the inlet and outlet are both in the ventricle now. And so same thing, you know, you can see here very, very deep. You're getting this, so you just have to pull back some. Sometimes you may not get this alarm, but you'll kind of see a little ventricularization on your aortic pressure waveform, and that can be a hallmark that you probably need to reposition and pull it back a little bit because you're probably flirting right at the aortic valve with the outlet. So you see this a lot in really sick hearts. Probably more particular in salvage cases. You can get somebody that starts out like this, you know, back on the curve and a little bit better, but when they have total decoupled aortic ventricular, so you see your red line really has flat flow, no pulsatility, your ventricle is way below, the heart is kind of decoupled, it is not pumping well. And so usually that is a sign that that is like the sickest of the sick Impella patients. Sometimes you'll get an Impella position unknown alarm in those situations, and that's just because they're not coupled, there's not good flow, the heart is very sick. And so it's always good anytime you see things like this still to check the position. But if you have a very sick patient, usually this is probably either somebody that's presented late, or you may have waited too late to put an Impella in. It's kind of like salvage last heroic measure. You can see this, and this is a bad sign. Any questions on CP and 5.5? I kind of think of them a little as one, other than just the monitoring of their groin sites versus their axillary sites. Okay, well, this is not the RP that we use now, but this was the old RP, but kind of same concept. The one now is just a very flexible tube. It doesn't have this curve to it anymore. But so the RP Impella that we have now can go IJ or groin. We here have had a lot more issues with IJ and sizing of women, especially, and clots and things. So I personally have been putting a lot more in the groin, which has been going much better. So, but it can go both places. It sits into the right atrium and dumps out into the PA. So in looking at your right heart parameters, we talk about this thing called a PAPI, or PA Pulsatility Index. There's a lot of markers of right heart performance. What do you think is the most of all the things that we can measure? A PAPI, CVP, PA pressure. What is the most important value to mark RV failure? Any other thoughts? CVP. Because CVP is in every calculation. And so CVP is the most important predictor of RV function. Same thing, you can calculate a PAPI. Sometimes I never know what to make of this. Somebody will tell me their PAPI is, let's say 1, but their CVP is normal. I don't know what to make of that. I usually don't make too much of it, honestly, early on until things progress. But when you have a really high CVP, you're trying to determine, is that coming from because the left side of the heart is failing and their wedge pressure is really high and they have too much volume overload and now it's just backing up and making your CVP high? Or is the RV a problem? Like, is your CVP high because the RV is failing? And the best way to look at that is to look at your PA pulsatility. So that's where PAPI is helpful. Basically, you're wanting to know, is the PA pressure normal, or is the, kind of as we talked about in cardiogenic shock, you lose pulse pressure, right? So that's kind of what PA pulsatility is looking at, is how much pulse pressure do you have in the pulmonary artery? You know, if you have really good pulsatility in the pulmonary artery, then your PAPI is probably going to be really high, because PAPI is calculated by the subtract your pulmonary artery systolic, diastolic over your CVP. So if that pulsatility and pulse pressure is really high, then your CVP is probably going to be, or your PAPI is going to be high. But if you have a very narrow pulse pressure in the PA and your CVP is really high, then it's going to be low. And so, and that kind of tells you, if your PA pressures are really high but you have good pulse pressure, that's probably driven by left-sided volume and pressure. If your pulsatility is very narrow, then that's probably driven by RV dysfunction. And then pulmonary vascular resistance, that kind of is just like the afterload of the RV. And so, you know, there are some pulmonary arterial vasodilators. The thing in our world, especially in cardiogenic shock, is you talk about things like Flowland and some of the true ones that they use in primary pulmonary hypertension. Those will make left-sided heart failure worse. So you have to be careful with some of those when you're talking about pulmonary hypertension driven by decompensated heart failure. So things like milrinone will reduce, that's one of the benefits to milrinone, is we talked about improving contractility. That does that in the right side and the left side, but it also will reduce the systemic vascular resistance and it will reduce the pulmonary vascular resistance. And so that's a benefit. Nipride will too. Nipride will reduce pulmonary vascular resistance. But again, you don't want to use like any of the PDE inhibitors, Flolan, any of those things in pure RV failure if it's not like driven by primary pulmonary hypertension. If it's driven by that left-sided heart failure at all, you will make that worse. So a right-sided Impella, often used post-MI. You can see post-LVADs. We don't really, other than we put in percutaneous LVADs with Impella, but in big transplant centers, post-LVADs, you'll see right heart failure. That's always the thing you worry about, is assessment of the RV after LVAD, and then massive PE, you can use RP support. It delivers 4 liters of flow per minute, either sits RA, IBC, depending on which direction you're coming, and it dumps blood into the PA. It decreases preload, just like we talked about with the Impellas. On the left side, you're truly sucking volume out and dumping it. So you're basically bypassing that right ventricle. It increases pulmonary flow. It increases LV filling. That's something you have to think about a lot. If you see suction a bunch on the left-sided pump, but let's say your CVP is 25, you have to start thinking about RV failure and not just being like fluid down. You can't give IV fluid. If you keep giving IV fluids or volume to somebody that has a CVP of 25, they will just get into worsening and worsening RV failure. But then as their body starts to clamp back up, as their arterial system starts to clamp back up, then you'll start to see kind of this redistribution of fluid. And if they come out of the OR with a 5.5, they may do okay from a right-sided heart standpoint, but within a couple of hours, you may have CVPs 25, and they may start to have suction on their pump, and that's usually a hallmark of you've got some right-sided dysfunction. And so measuring a PA pulsatility index and trending that is helpful. So this is from the IJ. So this is what it looks like from the IJ. You see it coming in from the neck and then dumping above into the PA. You really want it to be kind of above the PA bifurcation. That's hard to see just on chest x-ray, but chest x-rays every day, we talked about for balloon pump, also important for any MCS device, just to see what it looks like comparatively, make sure position is not changing. And then this is kind of what the screen looks like here. Again, it has a sensor that the PA pressure is never really lines up with your swan pressure. There is a way to look at a CVP screen on here, because that is something we've been very adamant about doing lately, and we'll probably protocolize, which is taking out swans. So like I told you earlier, this is the one time that we don't really use swans anymore. Usually they've already had a swan and will have a sheath in their neck and you can transduce a CVP. But it's really hard when you have this pump will suck things into the motor housing, and we've had multiple clots in the past and pumps shutting down, having other lines. And so we really try hard to de-line these patients as much as possible. Heparin is very important. We're going to talk about it for this. We changed our ACT goals a little while ago, probably a year ago. You think that's accurate? Something like that. Anyways, we changed our ACT goals too when we started having some pump clotting issues. The flow on the right side of the heart is so much lower on the left side, even in cardiogenic shock. And anytime blood has very slow flow, it wants to congeal and form clots. And so we increased our ACT target and RPs to over 200. And RPs are the one that are the most important to have heparin early. That's always the risk benefit, you know, especially in our world in the cath lab, it's not as a big deal. We use heparin all the time. It's more of a big deal in surgery patients, post-cardiotomy shock patients, because there's the balance of post-surgical bleeding plus needing things and anticoagulation for the pump. And so we've been running our RP, PT, or ACT goals above 200, and really, they really need to be on heparin from jump and no lines in place. So again, suction is often caused by malposition or volume. And so the right side in particular, you know, it's not a good time to start diuresing unless their CVP is still really high despite RV support. So always chest x-ray. You want to get a chest x-ray on every MCS patient. You want to keep the pump flow above P6 unless you're actively weaning. For the right-sided, no PA catheter until it's out. For the left side, you always want to have a PA catheter in place so that you know where you are and how to wean it. You have to be careful with RP impella flow. You do not want to get your flow so low on right-sided impellas because again, it'll clot. So that's why you see us, we'll do these wean down trials where we'll get an echo at the bedside and do a turn down echo for like 10 minutes, but you don't want your flow to be at P2 versus if you're weaning a left-sided pump, you can wean it all the way down really until P2 until it comes out pretty safely. And then you always have to watch your volume. You know, when you have a MCS device, you have to be careful about volume, flows, and some of those things. Also, hemolysis is something you see. Usually you will always see their platelets go down, always. When you have MCS in place, their platelets will go down. Their hemoglobin will slowly go down. That is usually subclinical hemolysis. But when they get clinical significant hemolysis, their urine changes, you'll see really rapid drops. You can see their bilirubin start to really go up. You probably have a pump issue at that point. You either have a clot in the pump somewhere, but the pump either needs to be exchanged, it needs to be repositioned, something has to happen if you start getting, because they'll get pigment nephropathy that way. If they start lysing a lot of red blood cells, they'll get pigment nephropathy. It'll stain their kidneys and cause renal failure, causes the bilirubin to go up. So you always have to be aware of thinking, is this clinically significant hemolysis or not? Because all MCS will have some level of subclinical hemolysis. Their platelets will all come down. And then, you know, in our world in cardiology, they've all gotten heparin. So you're always trying to figure out, could there be a component of HIT in there? And so you just kind of have to keep an eye on it. But just know, like, that is normal for platelets to go down. And then we've been checking the correlation to make sure for the first 24 hours with an RP that the PTTs correlate, that truly at an ACT of 200 that you're truly anticoagulated. So we're working on some formalized RP protocols, but it will include PTTs for the first 24 hours and then daily after that. And then a lot of us have varying practices. That's the thing. Cardiologists are all different. And so all of us put in devices a little bit different and manage them a little bit different. So there's two types of sheaths. It's very rare. It should be extremely rare for a patient to come up with a left-sided CP with a 14 French sheath in. So when we put in these devices, we use a really big sheath both ways. But normally you peel that sheath away and put in what's called a repositioning sheath. The thing on the left side is that is tolerated much better because you're only dropping like 5 French sizes. How much is it? It goes 14 to, that's what I thought, yeah, 5. But the right-sided device is not true. You go from like 23 French to, it is?
15, the sheath is right next to it.
Oh yeah, my sheath. So I in particular, I'm probably the one that does this religiously. Some of the others may peel away. I do not peel away RP sheaths. That drop in like 10 plus Frenches leads to bleeding. I rarely have left-sided pump hematomas, but right-sided pumps will hurt you. So this is the sheath that I use. It goes from the groin up to the IBC, and it's long and it's big, and there's a fair bit of dead space. And so you have to, we've been working on what's the best way to manage the sheath while it's in. And for right now, I've settled on aspirating. So I didn't realize this until not long ago that, you know, we manage sheaths in the cath lab all the time, but in the ICU, it's kind of managed a little different. You know, in the cath lab, you really have to aspirate a sheath, number one, to make sure it's not clogged. And you don't want to flush that right back through, because if there is some like little microclot, you don't want to push that back in. So you really should be aspirating, dumping, and then flushing with saline after. So we changed the RP protocol some to aspirate 10 cc's. This is a big tube. It has a lot of dead space. So you want to aspirate 10 cc's we're gonna try, we've been doing it the last couple RPs we put in and it's gone well so far, of KVO with heparinase. We're gonna change it to heparinase saline, 20 cc's an hour through the sidearm, and then standard purge with the standard ACT goal. But the things I've changed the most are this aspiration dump, and then you flush with 20 cc's an hour. I don't think it's going to cause, everybody's been a little worried about the volume. We'll have to see. So far it has not been a problem, and I think it will be fine. But otherwise you can develop a lot of clot in this tube if it's not aspirated. And then if somebody puts in a peel away, you just have to realize they may have a lot of bleeding around that peel away, so just be very cautious. All right, so a couple questions and we'll be done. Patient with mixed septic cardiogenic shock, started on norepinephrine, but contractility remains poor. What agent should you choose to improve contractility without increasing afterload? All those in favor for dobutamine, raise your hand. Okay. Phenylephrine, vasopressin, epinephrine. What drug increases contractility but doesn't really change afterload? It does not increase afterload. Dobutamine. Okay. Patient has a suction alarm. Echoes shows that the impella is 5 centimeters into the ventricle, directed towards the apex. CVP is 2. What's the best intervention? Number 1, do we think the impella is in good position?
Is it 5.5 or a CB?
Good question.
I was just asking.
Yeah.
It's a 5.5.
Let's call it a 5.5. I don't think it's in a bad position. Would you pull the impella back 1 to 2 centimeters if it's a CP? Would you give IV fluids, increase the impella flow settings, like go up to, if you're at P6, would you go to P7? Or would you add dobutamine?
B.
Yes, B. So again, 5 centimeters, some people, you could say that's too deep if it's a CP, but if your flows are good, it's directed towards the apex, probably fine. Here, your CVP's 2, so you know they're probably volume down, so they need some volume. Or you need to come down on your P level. That's the other thing that could be right in this situation. 58-year-old female presents with acute MI, placed on Impella CP, cardiac output initially improved. 2 hours later, the cardiac output falls, blood pressure drops, you're getting frequent suction alarms. CVP is 22, PA pressure 43/33, mixed venous is 40, cardiac index 1.7. What are your thoughts? What's happening here? Why are we getting suction?
RV's failing.
Yeah. Is the PAPI above 1 or less than 1?
Less than.
I think quick math.
I should have made the CVP 20. It would have made it a lot easier.
I'm like,
It's definitely less.
Okay, somebody tell me how to calculate this CVP. Don't say it out loud yet.
oh, sorry.
The packing?
Yeah. So 43 minus 33.
Divided
That's
by
right.
22.
Okay. So, and then what'd you say it was, Haley?
Like 0.45.
Yeah. So 0.45, so really poor. So this is a problem. This person needs either contractility for the RV. So in these situations, you can try inotrope. You could start any of them that you wanted to. Dobutamine, you got to be careful with milrinone, but you could try milrinone, or right-sided support. All right, a 65-year-old STEMI comes from outside hospital, transferred for cardiogenic shock management. They had an intra-aortic balloon pump placed at the outside hospital. The arterial line tracing shows balloon inflation during systole, not diastole. So instead of it increasing during diastole, pushing blood back to the coronaries and deflating in systole, it's inflating in systole. So what do you think is a consequence if that were to happen? Increased coronary perfusion, increased afterload, and increased myocardial oxygen demand, increased systolic blood pressure, or increased preload?
B.
Yes, B. Increasing afterload and decreasing myocardial oxygen demand. Do y'all see that? Okay. That's it. Any questions, comments, things you want to know?